Good evening, doctors. My name is Atul Suri and I represent Alembic Pharmaceuticals Limited. It's my pleasure really to welcome you all to this Ovigen D Plus Knowledge Beyond Boundaries webinar on World IVF Day. We are today indeed honored to have with us an esteemed panel of distinguished professionals and leaders in the field of reproductive medicine. Your online presence underscores our shared commitment to advancing women's reproductive health and well-being. At Alembic, our mission has always been to foster innovation and excellence in healthcare. We strive to empower healthcare professionals with the knowledge and tools that are necessary to improve treatment outcomes. With this, let me hand you over to Dr. Abhijit, who's from our medical affairs team, to take this entire webinar series, Ovigen D Plus Knowledge Beyond Boundaries, forward. Over to you, Dr. Abhijit.
Good evening, doctors. Thank you, Atul sir. Today's event is a significant one. It's a significant step in our direction to empower healthcare professionals with the knowledge and tools necessary to improve treatment outcomes. As you are aware, infertility affects 1 in 6 people of reproductive age group. World IVF Day is celebrated every year on 25th of July to recognize the transformative effect of in vitro fertilization on millions of lives worldwide since the successful birth of Louise Brown, the first test tube baby ever born in 1978. This day celebrates pioneering advancements in assisted reproductive technology that have revolutionized the field of fertility treatment and offered renewed hope to couples facing infertility challenges. So once again, a warm welcome to the Ovigen D Plus Knowledge Beyond Boundaries webinar. I would now like to extend a special welcome to our esteemed speakers and moderators for today's talk. I'll now first introduce Dr. Amit Patki, who is the president of ISAR. He is the medical director of Fertility Associates, Center for Assisted Reproduction in Mumbai. He is an honorary associate professor at KJ Somaiya Medical College, Hospital and Research Center, Mumbai. He is also consultant Ops Gynec at Hinduja Surgical Healthcare and Surya Mother Childcare, Mumbai. He has done MRCOG from UK, where he worked in London for 4 years and did a postdoctorate fellowship in assisted reproduction. He has to his credit 2 international patents in infertility and embryonic stem cell research. He is a proud recipient of Foxy Korean Award 2003, Mox Young Scientist Award 2005, and Asia Oceania Federation Award. So now I request Dr. Patki to welcome the session. Yeah.
Hi, good evening, friends. This is Dr. Amit Patki, your president at ISAR. I bring you greetings from ISAR on this wonderful day of World IVF, 25th July. As you all are aware, this is the date that the world's first test tube baby, Louise Joy Brown, was born. And it is not a day of celebrations because it has liberated millions of couples from the clench of infertility. I've had the joyous occasion of meeting Louise Brown a few times in meetings and conferences, and I can see that she's such a vivacious person, and her birth has not brought joy only to the family, but the world over. And that is why her parents aptly named her Louise Joy Brown. On this day, today, as we celebrate World IVF Day, we are pleased to have 2 excellent speakers in Dr. Nandita Palshetkar and Dr. Jayam, who will speak on 2 different aspects of infertility. So join me for this wonderful webinar, which is brought with an educational grant from Alembic, and I hope we will all enjoy this webinar. Thank you very much for joining.
Thank you, Dr. Patki. Now I will welcome Dr. Charmila Ayabo, who will be moderator for the first talk on ovarian stimulation in spontaneous conception. Dr. Charmila Ayavu is the Vice President of FOXY. She is the Chairperson Clinical Research Committee FOXY 2016-18. She is on the ICOG Governing Council members 2021 to 23. She was the National Coordinator for UNICEF FOXY PCA, Medha FOXY PG program, and ISAR Gurukul 2022. She is a member of WHO CRO MDSR India Committee. She is a past secretary of Trichy OBGYN Society. She is the current president of she was the president of Menstrual Hygiene Management Consortium 2018-20, and she is the joint secretary of Gestosis India Association. So warm welcome to you, Dr. Charmila. And I now hand over the session to you to welcome our guest speaker. Thank you.
Thank you. Thank you so much, Dr. Abhijit, for that very kind introduction. It's my honor to introduce Dr. J.M. Kannan, who's a mentor for many of us, as well as she's one of the pioneers in IVF in Tamil Nadu and South Zone. And Madam has got almost 2-3 centers under her name. And on IVF Day, to introduce Madam as a speaker is my honor. She's going to talk on ovarian stimulation protocols for spontaneous conception. And I'm thankful to Dr. Amit Patki and Dr. Asha Bakshi ma'am for giving me this opportunity. Madam has been the Vice President of FOXY in 2018, has been the FOXY Adolescent Committee Chairperson of 2013 to 2015, where she won the Best Committee Award. She's an Emeritus Professor of the Tamil Nadu MGR Medical University. As a student of medicine, she has won almost 13 out of the 15 medals for the year, and she's bagged the President of India Award for being the best student in medicine in 1968. She has continued her excellence during her post-graduations and obtained university first rank in MD and Dr. A.L. Mudaliar Award for the best MD postgraduate in obstetrics and gynecology. And let me tell you personally, I know that she reads almost 14 to 16 hours a day. She doesn't sleep. She works and then she reads. And it's an honor to have Madam talk on a subject which is very, very close to heart. May I request Ma'am to give her talk on ovarian stimulation protocols.
Thank you, my dear Charmila. And I'm extremely happy to be there on this World Population Day. When we started at IVF, we know the hurdles we have gone through. Now you have all the culture medias, needles, everything disposable. But those times in 1980, 85 to 92, we have to make the needles and other things. How many sessions I have attended at Singapore and other places. And now it is just like a ice cake. But it was a hard rock when we started the IVF. They say Louis Brown was born after 300 failed attempts of IVF by the Robert Edwards group. And even in Louis Brown, she had an ectopic. She had a 24 weeks fetal loss. Then only that baby came. This is a hard story of this IVF. Now, on the day of IVF, I'm going to speak on spontaneous conception. As the knowledge beyond boundaries is the topic of headline today. So my topic will not be getting stuck to any textbook reference or to any standard guidelines. It will be of more of this thing which has been done by people all throughout the world. Of course, we all know very well, for any of the conceptions to occur, except when you are doing a donor program or frozen or anything, the hypothalamo-pituitary ovarian axis is very, very important with all the hormones which I have detailed in the beginning. And we all know very well the follicle is FSH dependent follicular growth. You see from 2 mm to 7 mm. That is the size we see around day 3. For that 2 mm, how much of FSH is required? When it comes to 15 mm, how much of FSH is required? When it comes to 20 mm, almost there is no FSH. Again, there is a small FSH surge which is required so as to produce 20 mm follicles with a recruitment, selection, early dominance and late dominance. And this is what we are dependent on for a follicular growth. And we all know well that the low FSH concentration does not allow the follicle to grow. Automatically, they get atretic. Even for the selection and dominance, we cannot have a high spike alone. We have to require a curvilinear pattern. FSH level with the follicle size which has been shown for a spontaneous one. If you are giving exogenous HMG or FSH, if the level is maintained well, we get multiple follicles being stimulated, and if the window is appropriately maintained, we have the expected number of follicles, whereas if the window is not maintained, we go in for ovarian hyperstimulation. And we always monitor all the follicles, whether it is for a spontaneous conception or for an aortic conception, with a transvaginal ultrasound estradiol level by 8 days to 10 days, and with 17 mm follicles, even in a single follicle. If you want, we give HCG. No need for a luteal support if you have a single follicle, if you are not doing an embryo transfer that time. We all know well that at the same time, we have to have a good endometrium by day 6 to 7 mm. By day 9 onwards, we should get the triple layer of 9 mm, which is required, meaning thereby that the TOG of the oocyte and endometrium starts pre-follicular, and once the zygote is formed, the embryo maternal communication goes on for the proper transport in the fallopian tube and implantation of a good embryo at good endometrium. March 24, there was a big BBC news, fall of a cliff after 35 years. This age is one which is unremarkable in any woman's life who wants to get pregnant. But we know well at that time, our levels falls down. Women who have conceived by early 20s, 30s, do not bother about it because it becomes a continuous process in her life. Is it really 35, 38 or 40 in the present scenario when women are looking for their executive positions and want to start a pregnancy only after 35 years? Of course, the cryopreservation of the gametes has come in, but still if she wants to have a spontaneous conception, how better are her chances? 35 years, yes, the chance is 29%. By 39, it comes down to 25. Quickly, in the next 1 year, she comes down by 3%. Next 1 year, by 41, she comes down by 4%. What is 3% and 4%? By the age of 41 to 42, it goes to 7%. At the age of 42 years, any woman who still says, I want to conceive spontaneously on my own, kindly inform her that she has got 1 in 6 chances or 1 in 7 chances to get a pregnancy on her own, unless she is interested in quick baby. Now, when this comes, it is always when we want a spontaneous pregnancy, we always want only a monofollicular development without complications with any novel protocol if it is also possible in these cases. The oral medications which are standardized right time immemorial in the last 40 years, even after Louis Brown till date, is clomiphene citrate, tamoxifen, cyclophenol, and aromatase inhibitors. They all are required to have the growth, right? This thing with the FSH coming down, and from the day 3 to 20 mm after ovulation. We all know how to use clomiphene citrates. We always know that we have to start by day 3 to maximum day 5 and do an ultrasound and then decide on what is to be. Kindly note, in ovulatory women, if you want to support with clomiphene citrate, it increases the GnRH pulse frequency very nicely at hypothalamus. Thereafter, having a good work on the FSH, LH, progesterone, LH, and other things, and it has got no effect on the endometrium clomiphene citrate. Whereas estrogen and other things, it goes on very well. In anovulatory women, especially in polycystic ovarian syndrome, where already the pulse frequency is a damaged one, abnormally high, CC treatment, clomiphene treatment does not increase the frequency. It only increases pulse amplitude. It only makes the pulse amplitude go up, does not. So in ovulatory women versus anovulatory women, for spontaneous conception, we should know well the limit of the GnRH pulse frequency, which is going on the 6. Of course, for this, we add some of the adjuvant drugs. Earlier, we used to add metformin, acetylcysteine, estrogen, and HMG. Present days, we are adding up something very good, which I will come at the soon close. The clomiphene citrate has to be at always a dose of maximum of 150 milligram 5 days, not more than 7 days, and always started by 2 to 5 days of the cycle, maybe 6 cycles is given. Can we make modifications in clomiphene citrate protocol to improve the spontaneous consumption outcome? Or would you immediately switch on to aromatase inhibitors in these patients as a first-line option after cessation? This paper 2014, which was quoted by Bharti Dore Patil, who is a very big worker in all this endocrinology of infertility, she has looked at the paper. With the paper talks very interestingly luteal phase support to the clomiphene citrate versus post-menstrual clomiphene support. In the patient group 1, it was given on day 5. In the group 2, they gave 100 milligram clomiphene daily after the luteal phase with medroxyprogesterone acetate for 7 to 10 days. And immediately after finishing the last dose of medroxyprogesterone acetate, they started clomiphene citrate. That means they did not wait for withdrawal bleeding. In these cases, they found a small edge of increase of pregnancy, 8.7% per cycle in the group 1 and 10.3 in the second group. That means luteal phase support of clomiphene citrate also works in these patients. Now, in polycystic ovarian syndrome, when Bharti was asked about many more protocols for this, she went on to say about these things. If there is no ovulation you see with clomiphene citrate, maybe increase the dose to 10 days, maybe add HMG also. And if you find the patient is anovulatory after 6 cycles of clomiphene, you take it as clomiphene resistant and proceed to the next cycle of treatment. And in 2015, the stair-step protocol was brought with clomiphene citrate, increasing the dose to 100 milligram per day and also making it for a longer period. But however, the ovulation rates were almost similar in these cases. But however, the pregnancies were found to be little more in the second group, and it made that the stair-step protocol only reduces the number of cycles and makes a patient more comfortable by achieving an early pregnancy. Maybe this is also acceptable to the patient because the patient does not want to come every month to the hospital to get a spontaneous conception. If she is happy with the stair-step protocol in 2 cycles and gets a pregnancy, she will be the best person in the world. In these cases, do we estimate the estradiol level and what happens to the estradiol level? The estradiol level is more corresponding to the patients who are in the average BMI group, not in the obese patients. Now, to come to a little more on clomiphene citrate, it acts on the FSH and FSHE2. When we think of the letrozole, I have put it here. Kindly note letrozole does not have any effect on the FSH level. It has more on the estrogen level. Right. Clomiphene citrate, spontaneous conception. Every month, 60 to 80% of the patients get ovulation. 15% of the patients per cycle can conceive, and amenorrheic women are more likely to conceive than oligomenoric women. So giving clomiphene citrate in amenorrheic women in 2023 has been found to be more helpful. Now coming to the aromatase inhibitors, when they used alone, they always develop 1 or 2 follicles. When they are used with other, that is why it is significantly being used to reduce ovarian hyperstimulation syndrome. If you are going to give aromatase inhibitor and also give FSH, adding letrozole on the day of FSH is not good. Please give letrozole and then follow it up with FSH, which is a good way to reduce the OHS and have a good action. Aromatase inhibitor directly acts on the ovary and produces these changes. And the dose is 2.5 to 5 milligram. Higher doses result in persistent of the aromatase inhibition and estrogen level, too low for normal endometrial receptivity. That is why higher doses are not being recommended. Government of India is very particular about 2.5 milligram for 5 days only. But however, we are giving 5 milligram for 5 days, and this has to be not noted as a patient for fertility care. And if combined with FSH, give it sequential, not overlapping dose. There is a paper on this, also on the impact on the anti-Mullerian hormone, which is very much talked of, especially in polycystic ovarian syndrome. Spontaneous conception in polycystic ovarian syndrome with letrozole in a patient with AMH of 4.5 and above is not statistically good, meaning thereby you better look for a patient with less than 4.5 AMH so that your letrozole is able to produce a pregnancy in that PCOS woman. Now, there is a drug, melatonin, which is talked for the past decades, and all women with polycystic ovary who have not responded to clomiphene citrate. Maybe the body mass index is to be looked at for giving the melatonin in those groups. And probably it can also increase ovulation pregnancy. There was one paper long ago rating at level years. Thereafter, it was not too much accepted. What can we give more for these patients who want a spontaneous conception? HMG, urinary FSH, all these things have got an LH activity, and they can be given only up to 75 IU to 150 IU so that we do not go in for ovarian hyperstimulation. Kindly note that we do not do any down regulation of these patients, even either depending on the reserve age or previous response for getting a spontaneous conception. Can men matter too for a spontaneous conception? Yes, please. Men also have into this. Patients have been found to have less chances of conception even after 35 years for man also. And when he is up 40 plus, he also gets a downfall by 9 to 16%. Men can conceive at any age is not the dictum which is going on now. Probably all adjuvants seem to work better for men, especially CoQ10 is now coming up with a bright future. Tests which are required for these men also require including the postcoital test, anti-sperm antibody test, along with the semen analysis as per WHO recent guideline, dual patency test, documentation of ovulation, hysterolaparoscopy in cases, ovarian reserve, and sperm function test if they are not able to conceive in the stipulated time. Then we move on to the unexplained infertility couple who want to have a good pregnancy on their own. Probably we do very few tests. We do more with laparoscopy, and with the results, we have to look at it correctly, and the results have to be interpreted also correctly as per one of the recent workshop which has been done on unexplained infertility, in which Dr. Madhuri Patil from Karnataka has been one of the members there. And she says very clearly, track down the factors which could change the pattern of the unexplained infertility. Look for a review of the factors, not look at the same factors. Look at all these ovarian, tubal, peritoneal, endometrial, embryological, and include psychological factors also. In these cases, expectant management may be to give clomiphene citrate and timed intercourse or IUI. Superovulation with ovulagents like clomiphene citrate may be more effective than letrozole in unexplained infertility. Treatment with gonadotropin seems to be more effective than CC or letrozole, although there is a greater risk of multiple gestations. Despite its costs and widespread use, IVF was no more effective than gonadotropins with IVF, but may accelerate the time to clinical pregnancy. 40 plus want to have spontaneous conception or IUI or IVF. They have looked at it as early as 2010 itself. It was looked at it, and they have found 2 cycles of controlled ovarian stimulation or with IUI, immediate IVF, immediate IVF seem to have more chances of pregnancy. So 40 plus, I would rather prefer the patient to have only 1 or 2 cycles looking for a spontaneous conception, quickly move on to IVF conceptions only in these people. Tamoxifen is a one which has been very much in all textbooks, but no significant openosis over CC has been seen. There has been a big meta-analysis only in 2005. After that, the tablet has become little silent in patients to be supported for spontaneous pregnancy. Now come to some of the adjuvants. Coenzyme Q10 is an antioxidant. It is a nutritional supplement. It cannot guarantee conception. This is what is all written in all the books. CoQ10, however, is abundantly available in all the high energy requirement cells, such as sperm and egg cells also. CoQ levels decline with age. How can it be giving energy? So it is often recommended as a supplement for people with infertility. Its role in protecting the mitochondria from oxidative damage and in synthesizing adenosine triphosphate has been extensively proved. Maybe it is not proved for an infertility patient with randomized controlled studies, but it is proved on its effect on mitochondrial damage and ATP synthesis. And in sperms also, it has been proved to reverse dysfunction caused by the oxidative stress, free radicals. More studies are coming up. So to summarize on CoQ10, I will say the effect on the cellular level is abundant, but the effect on infertility care is not much. Probably we need to do more randomized control studies in our Indian scenario, supported by pharmacological agents, to find out how much CoQ10 can support us in Indian scenario, as we know that it declines with age. The next drug, colorfully made it, is myoinositol. It has been said because it is considering with insulin sensitivity, insulin resistance, it has been very much studied on glucose utilization and testosterone level, and it has been proved to give good quality oocytes. And it is also talked to restore the menstruation and normal ovulation. However, improving the pregnancy rates has not been standardized by any standard guidelines. Now, coming to the dehydroepiandrosterone. This is one, the latest paper I took is from Frontiers in Medicine, which is a indexed journal, February 2024. There is an article which says, successful pregnancy with oral DHEA treatment in hypoandrogenemia in a patient with recurrent pregnancy loss more than 5 times with a fetal loss of 24 weeks also. She has been put on DHEA 25 milligram twice daily with clomiphene citrate from day 3 of the cycle, and HCG was also given for the LH surge. And she has conceived after the 3rd cycle, and she has gone through and delivered a successful, healthy child. Prior to conception, DHA supplementation is known to improve spontaneous pregnancy, a measure of improved follicle function in women with low ovarian reserve. But however, even though this paper is recent and gives a little boost for DHEA, it is still to be connected with the standard guidelines also. Are we missing the melatonin as a big key? It's a sleep hormone. It's a potent antioxidant secreted by various tissues in the body. Its a primary source is pineal gland in the brain. The melatonin pivotal function is safeguarding the cells against oxidative stress. The circadian rhythm, which significantly influences the reproductive system, orchestrating the secretion of the crucial sex hormones, is also guided, controlled by the pineal gland, of which the secretion is dominantly melatonin. So, to end my lecture on spontaneous pregnancies with all the drugs which I have said, conversations are always pleasant. Discussions are very, very interesting. Debates are productive. In any event, conversation, discussion, and debates are always positive approaches. They ignite people's passion, their creativity, and bring their best to the ideas on the table for the clinicians. Thank you all for this active participation on the World Consumption Day. Thank you very much, Alembic, for this opportunity, and Isar for giving me the opportunity, and Charmila for chairing the session. Over to the organizers.
Thank you so much, ma'am. As always, very precise and clear. Are there any questions in the chat box? Subbu, tech support, are there any questions? Ma'am, the one question I would like to ask, the topic is actually induction in for a spontaneous conception, that is not for an IUI. So
Yeah.
for PCOS patients, we accept that we need to do an ovulation induction. But for a girl who has got an unexplained infertility and has come, would you advise oral ovulogins, or you would like to go for an injectable?
That is where I put there, especially PCOS, and now very much look into AMH level. If you have an AMH level of above 4.5, please be guided that she may not respond to our ovulogens. She is the one who requires the next step of drugs with gonadotrophins. That is why I quoted that paper on polycystic ovarian syndrome and AMH level. Even in the last year guidelines, we expected that they will give a standard cutoff on AMH level. But they were this thing confused and said any level after 4 to 5 may not be good for ovulation induction. But this paper very clearly, it's a randomized control study which says 4.53. Maybe we take, if the PCOS is having only 3 to 5 AMH, probably we should be able to do better with oral ovulogins.
No, I'm asking for a person who's not PCOS.
Who is not a PCOS, if she is an unexplained infertility, as Madhuri Patel has given in her workshop, probably we have to go for 2 to 3 cycles with oral drugs. And depending on the age, whether she is 35 below or 35 above or 40 above, the guideline has to be changed.
Thank you. And the chronic long dose, the low dose protocol, the PCOS, I think with the stair-step protocols of letrozole and clomiphene, I think the injections can be actually kept aside for some period of time because they seem
That's
to
what
work.
they said. The stair-step protocols shorten the time to pregnancy. So they have put the patients on stair-step protocols and regular protocols. On that study, they have found the time to pregnancy is shorter with stair-step protocol, meaning thereby that they get pregnant within a few. We are only standard talking about 6 cycles. They conceive in the 2nd and 3rd cycle, limiting their time to come to the hospital, which is better with stair-step protocol.
Thank you so much, ma'am. Dr. Nandita madam has joined. Can I ask Dr. Asha Bakshi ma'am to take over? Thank you, ma'am.
Thank you very much, Charmila. And it was an excellent presentation. Congratulations, madam. And so nice to see you on the World IVF Day. And I would like to congratulate all of you on the World IVF Day. And today, congratulations, madam. And so nice to see you on the World IVF Day. Today, okay. So today we have very excellent topics, and already Dr. J.M. Kannan has thrown light on the ovulation induction in women who are not undergoing IUI and ART. And now we have Dr. Nandita Palshetikar, who is a rare combination of intelligence, beauty, and everything. I consider her as a very good clinician, academician, and a leader. So may I have her? Yeah. And she has represented all the societies. Like she has been past president of ISAR, she has been past president of FOXY, she has been professor in DY Medical College, teacher in super specialty degree, FNB reproductive medicine, and has been president MOGS and president MOGS. And President IAG also. So whichever organization you talk about, and she has really held that topmost position in those organizations. And she has been member on national guidelines for accreditation, supervision, and regulation of ART clinics. She's very updated with all the topics, and I'm sure today she's going to do justice with the topic. To you, Dr. Nandita.
Thank you, Asha. Thank you for that wonderful introduction. Let me just hold on. How do I? I've shared the screen, right? Yeah.
But I can't see, we can't see. Yeah.
No, wait. I want to reduce this. How do I? This.
Tech support, can you just help?
Yeah.
Nandita, click this Olympic talk 25th.
No. That's okay. Where is it?
Or you have put it in the PowerPoint down, you take it.
No.
Now
See,
you
but I want this to go away, this column, which is all of you, I can see. I want that to be reduced. How does that reduce?
On the top, means go on the top on that and click your.
Okay, yeah. Thank you. So I can see my full slides, no? Yeah. Thank you so much. Dr. Jem, speaking after you is a big task. You were fantastic. You spoke so well and really enjoyed it. And Asha, it's always a pleasure to see you. And thank you so much for being such a good friend and also appreciating the hard work that we women put in. I think, thank you very much. You are one of them also. And Charmila, it was good to see you also. So today my topic is poor ovarian reserve. What I have realized is literally actually 20 to 25, maybe even 30% of my practice is poor ovarian response. And it's one of the most challenging tasks for us. Patients may usually have a higher FSH level, lower AMH level, but more than the high FSH level, I'm seeing a lot of young girls with low AMH levels and low number of oocytes retrieved when we use the protocols. And that is the problem which all of us are seeing, and that is poor ovarian reserve. So it may either be because of it. Asha, you need to mute. The POR may be because of advanced maternal age, iatrogenic reasons such as ovarian surgery, pelvic adhesions, obesity, and today even because of pollution. And a lot of times I do precision medicine and we get genetic polymorphisms which are actually responsible for poor ovarian reserve. There's more than 30 genes which are responsible for poor ovarian reserve. So you find them in a lot of patients. And I think, the unexplained part which Jem was talking about, today with so many advanced tests and all, it's probably shrinking, and we are able to offer tests for a lot of things today as compared to what we did maybe 5 years ago. So today on, I think it's nearly 45 years of IVF. It's the World IVF Day. I want to wish everybody a happy World IVF Day, and want to take off where today the technology has taken us. So if you look at Eshe, the Bologna criteria, you had to have 2 out of 3 criteria. That is, one was age, more than 40. Second was previous ovarian response, if it's less than 3 eggs, with a conventional stimulation of 150 FSH, and an abnormal ovarian reserve test. So it did cover everybody. But what happened was, because of this poor ovarian reserve, there we see a lot of cancellation rates, lower pregnancy rates per transfer, and cumulative pregnancy rate is also lower because you have less number of embryos. So in 2016, a group got together and they caused the Poseidon criteria. This is an individualized treatment approach for poor ovarian reserve. And this criteria actually helps us to do that. If you look at it, group 1 and group 2 are where the ovarian reserve markers are normal. AMH more than 1.2, antral follicle count is good between 4 to 9, that's subgroup B, and subgroup A is less than 4. And the group 3 and 4 are the ones with actually the poor reserve. So group 1 and 2 are the ones which unexpectedly give us a poor response. And group 3 and 4 are the ones with the poor reserve. And we do expect, poor poor response. So age, AMH, AFC, and number of oocytes retrieved. These were the criteria used in this. And an advantage of Poseidon criteria is it improves the ART outcome. It promotes the patient-tailored approach and maximizes IVF success. And the treatment is very beautifully given in this, Frontiers of Endocrinology in 2019, where it was published that for pre-treatment protocol of Poseidon 1 and 2, so your AMH, AFC is normal, but when you use stimulation, you get lower number of eggs. So you can actually use the ART calculator, and the genotype screening over here would help. You would think FSH polymorphism is more common, but no, the AMH polymorphism in our Indian population is seen more. Of course, you can consider androgens in selected patients, especially those, the markers are on the lower limit of the normal. So supposing it is 1.1, then the androgens would really help, like DHEAS or testosterone. So we have the Poseidon group 1. The stimulation protocol is simple. FSH dosage, if required, 75 to 150 maximum. I usually start with 300 if the response has been poor. And in Poseidon group through you immediately start with 350 and consider DO-stim approach. Sometimes in these patients, if you stimulate in both the follicular and the luteal phase, you will get better number of eggs. Even that 1 egg extra is really of use in these patients. So triggering or retrieval, consider antagonist regimen, GnRH analog trigger, and elective embryo freezing in case of AFC more than 16 or AMH more than 3.3. See, these are the ones which have the polymorphism probably and are responding. So use the GnRH trigger. Even if you're seeing 3-4 eggs growing, just give the GnRH analog trigger. And consider pre-implantation generic aneuploidy in Poseidon group 2, in particular patients more than 38. But of course, PGTA can be done if you have more embryos, and that's what the fight is about. So embryo pooling is the way to go in these patients. Consider a single blastocyst embryo transfer. Okay, so the advantage of Poseidon criteria is, I'm going up again, sorry. And the Poseidon group 3 and 4. What you need to remember is you can use a long agonist or the antagonist. I use only antagonist protocol in my practice. 1 minute. कमला, ये फोन जरा दे दो उनको, गाड़ी आया होगा, जरा कृतिका को बोलो ये फोन आंसर करे. Hello, Polo. Sorry, people. Poseidon group 3 is the long, I use the antagonist protocol 300. No, I start with 450 usually. And the measure of success of this protocol is 4 to 7 oocytes. And remember that when your patient is younger, even if you collect 4 oocytes, it's fine. So stick to it. Sometimes I'm collecting even 2 oocytes. And remember, the response of the patient is always better if you do stimulation one after the other. Then Poseidon group 4, of course, 450 is what I use. And for the older age group, you want a total number of 12 oocytes, which give you 1 euploid blastocyst. So in group 3 and 4, the ovarian reserve is low, and DO stimulation can be an option in young patients where aneuploidy rates are really very low. So day 3 versus day 5 transfer, consider day 3 embryo transfer to limit culture time. And especially there was a very good meta-analysis by Hassan Salam, and he recommended in poor ovarian reserve, you should transfer on day 2 rather than day 3. So, but now with better culture conditions and things have changed, and that was 10 years ago, we are definitely doing day 3 transfers. Women can, of course, be offered blastocyst transfer after adequate counseling of possibilities of cancellation of transfer. I think 40% of the cycles, sometimes when you have a low EMH, do get cancelled because there are no blastocysts. The commonly used stimulation protocols, Antagonist protocol is my favorite. That's the one I use, but you can also use agonist protocol. You can use microdose flare protocols. A lot of times I use letrozole or clomiphene citrate combination with HMG protocol, agonist or antagonist protocol, RH versus RH, FSH plus recombinant LH. I think for older patients, I prefer the combination of FSH plus LH. So treatment regimens, high dose gonadotropin, you can use HMG or RFSH plus RLH. And there's another one which is not very popular, but people are using it. It's 100 to 200 of international units of HCG per day. And also you can use luteal FSH start. GnRH antagonist versus GnRH agonist. I prefer the day 6, the flexible dominant follicle 14 protocol, but you can use either and the success rates are same. Natural cycle or minimal stimulation. Yes, that can also be used, but remember, it is not completely natural cycle. It's minimal stimulation, and plus you use the HCG to trigger that oocyte so that you can time the pickup. But you know what? It is number of pickups against the drugs. So I think the choice should be given to the patient, because if she's getting a single follicle every time you stimulate, then once in a while it can be a minimal stimulation, because giving her a high dose of HMG doesn't work. And of course, I use adjuvants like growth hormone. DHEA is my favorite. Coenzyme Q10 is something that I use, and melatonin is something which I really use. Of course, testosterone, but I don't use it so much. But DHEA, coenzyme Q10, and melatonin is something. And growth hormone we add to the protocol. I don't use it before the embryo, before the stimulation, but I start it with day 1 of the stimulation and continue it to the day of the trigger. So schematic overview of the ESHRE guidelines, which were published in 2020. So you can use antagonist or agonist protocol, 150 to 300 international units of gonadotropin. Of course, ultrasound monitoring, endometrial thickness, estrogen level, which I normally don't do unless there's only 1 or 2 follicles. Like today, I did do it for one patient who's actually undergoing a gender change surgery. So she wants to freeze her eggs before she, undergoes her surgery. And what they are planning is first doing a mastectomy and then subsequently a ovarectomy. So after 1 year, so she wants to freeze, but her AMH is low. And today we had just about a couple of follicles. I did the E2 level for these patients, but sometimes you need a E2 level to guide you. Of course, the trigger can, we give a dual trigger, which is HCG plus GnRH analog in low responders. And you can give the luteal phase. What I use is, I use dydrogestone, I use micronized, I use injectable, I use a combination of these for the luteal phase support. Adjuvant therapy. I think adjuvant therapy is really, really, these are patients where you don't have an answer for. And a lot of times, what I have seen is if the adjuvant therapy is given for a long time, it does make a difference. So what I do is dehydroepiandrosterone, DHEA supplement, testosterone is something which you can use. These are androgen supplements. They increase the androgen level, make the, the granulosa cell and the Tika cell sensitive. The FSH receptors are made sensitive, and they increase the receptors and help you in getting more follicles. And then androgen modulating agents like letrozole and aromatase or aromatase inhibitor, steroid hormones, estradiol and progesterone, recombinant LH, clomiphene, growth hormone, coenzyme Q10. So let's look at DHEA. This is a meta-analysis, and these are 9 studies. And if you can see the number of oocytes retrieved, if you take these 6 studies, the number of oocytes retrieved are more in the DHEA supplemented group. if you look at the clinical pregnancy rate, also it's the risk ratio is 1.27. It's definitely better when it's supplemented with DHEA, and the live birth rate is 1.76. I think that is very good, especially in the DHEA supplemented group. Then you come to the coenzyme Q10. Okay. I think before you jump to coenzyme Q10, you must understand that coenzyme Q10 plays a very important role in the mitochondria. And mitochondria are very, very important in reproductive function. The oocyte has the largest number of mitochondria in any cell. You know, the heart has nearly maybe 400 to 500 mitochondria, but the mitochondria in the oocyte is 2 into 10 raised to 5. At least 1 or 2 orders of magnitude that the somatic cells like muscle and neurons that have high energy requirements. The functional status of the mitochondria actually contributes to the quality of the oocytes. It plays an important role in the process of fertilization and embryo development. Failure of the oocyte to increase the number of mitochondria during maturation may lead to poor embryo outcome. Mitochondrial nutrients may be able to reduce the risk of trisomy and other types of chromosomal aneuploidy related to oocyte aging via increasing energy for chromosomal disjunction. They actually help in repair of the chromosomes also. So I think having good mitochondria is very, very important. And coenzyme Q10, it's the most essential function of coenzyme Q10 is the transport electrons in the mitochondrial respiratory chain. So primary deficiency predominantly manifests as a mitochondrial disorder. And it actually affects all parts of your body, the brain, the eye, the ear, the heart, the kidney, the muscle, etc. And the oral coenzyme Q10 gets absorbed in the intestines, goes to the lymph, and then is transmitted to the blood. So mechanism of action, it acts directly on the mitochondria, probably related to the electron transfer. Crucial role in the production of cellular ATP. It reduces oxidative stress within the ovary, protects the DNA from free radical-induced oxidative damage, protects the stability of the cell membranes by maintaining their flexibility. Extent of tissue uptake of coenzyme 10 correlates with the degree of tissue deficiency, acts an anti-apoptotic, and it is well known that apoptosis is the main mechanism involved in follicular coat atresia. Actually, it binds this sugoshin molecule which is there, which is required to it's required to keep the adhesions in the chromosomes. So this is how it prevents chromosomal damage. Clinical evidence, this is a study where follicle size was 18 mm and endometrial thickness on the day of the HCG was significantly higher in group A compared to group B. The clinical pregnancy rate were 21% in group A compared to 10% in group B. Miscarriage rate was 14% versus 33%. So those who were supplemented with CoQ definitely fared better, and it can be considered as a promising treatment. So the same thing, higher fertilization rate, high quality embryos, and significantly less women treated with coenzyme Q10 had cancelled embryo transfer because of poor embryo development. More women from the treatment group had available cryopreserved embryos. So this not only increases your clinical pregnancy rate, but also your cumulative pregnancy rate. And as you can see, this is a beautiful network meta-analysis of all the adjuvants in POR, and it was published in 2020. And you can see that clomiphene versus control, it's okay. Clomiphene is better. LH is much better. Estradiol is 0.43. Then let me growth hormone definitely is 1.36 ratio. Estradiol is 1.35 ratio. So it's very good. And, it gets the cohort together. So in poor responders, what we do is we give estradiol priming prior in the luteal phase. Growth hormone, definitely. Testosterone, it works. But the T-transport trial says testosterone doesn't work. But I feel if you divide the patients into Poseidon group and those younger patients with a near normal AMH would probably benefit from this. So you have to divide the patient, and a certain subgroup of patients it would help. HCG definitely works. Coenzyme Q10 and DHEA are both shown to be very efficient in getting good clinical pregnancy rates. So DHEA and coenzyme Q10 treatments resulted in a significantly higher clinical pregnancy rate of odds ratio of 2.46. HCG, estradiol, and growth hormone had the highest number of oocytes retrieved. Testosterone and growth hormone treatment led to the highest number of embryos transferred. So what are the other strategies that are there in POR? Platelet-rich plasma is something, intra-ovarian infusion. So when I do the pickup, I infuse platelet-rich plasma. And remember that once you infuse it, you start doing the pickups immediately. Or you can give 3 cycles of platelet-rich plasma with every pickup that you do, and it definitely helps. Then autologous stem cell ovarian transplantation. Also, it's in the preliminary stage, and a lot of articles which show that the stem cells in the ovaries, when you inject them, they definitely improve the number of oocytes that are there. And then, of course, mitochondrial replacement therapy, which is Augment. It's a technology which is available in US, but it's not become very popular. And right now, there's mitochondrial transfer by Nuno Costa, and it is amazing. I met him in Eshrei, and he's really excited about the whole, mitochondrial transfer and aging of the oocytes, which is there, and we can really use it to improve pregnancy rates. Melatonin. This is something I want to share with you all. This is a drug which I've been using for 5 years. I heard a lecture on melatonin by one of growing older, can't remember names, but he gave such a beautiful lecture. I think maybe it was 10 years ago. He gave such a beautiful lecture on melatonin, emphasizing the importance of melatonin in our reproductive function, in aging, in every aspect of the body. And as you know, it's a pineal gland hormone, plays a significant role in regulating circadian sleep-wake cycle, reproductive physiology, and immune function. And that is why when we advise patients, it's very important, I tell them that they must get 8 hours sleep at the right time, because 10 o'clock, if you go to sleep and wake up by 6 o'clock, the melatonin secretion is the best at that time, and it really helps your body regenerate, helps your oocytes regenerate. So it's a powerful free radical scavenger and a broad spectrum antioxidant. Stimulates a number of enzymes that are either involved in metabolizing potentially reactive species to harmless molecules, or inducing the synthesis of other endogenously produced antioxidants. You can see this diagram where you have the theca cells, where you have the granulosa cells, and all of them, because of the melatonin, it has a good effect on the oocyte. It's anti-apoptosis. It controls the ROS, and it gives us a healthy oocyte. In fact, the chance of aneuploidy with the use of melatonin is also less. So melatonin in the follicular fluid is produced by granulosa cell, but in addition, it is taken up from the blood also. It regulates sex steroid production by regulating steroidogenic enzyme activities or their gene expression in the thecal cells and the granulosa cells. It regulates the LH mRNA expression, the BCL2 and the Cas3 production, IGF and TGFB activity, and gene expression and maturation inducing hormone activity. Macrophage and granulocyte cells, granulosa cells produce ROS, and melatonin modulates the SOD, GPX, and CAT gene expression in granulosa cells. excessive ROS induces apoptosis and results in follicular atresia. However, increased levels of melatonin in follicular fluid scavenges ROS through its direct and indirect antioxidant action and prevents atresia. The follicle may be rescued by melatonin and continues its growth to become a dominant follicle. And remember one thing, I was talking about precision medicines, and these are the enzymes SOD, CAT, etc. These are affected. High doses of antioxidant should be given to the patient so that they can overcome these polymorphisms and give you better results. Melatonin levels and embryo quality in IVF patients with POR, a comparative study. 85 women were undergoing IVF, ICSI, and normal ovarian reserve were 27, pathological DOR was 25, and physiological DOR was 33. Melatonin levels in patients' serum and follicular fluid were assessed. Correlations between melatonin levels and indicators of embryo quality. Melatonin levels in the follicular fluid and the basal serum of DOR pathology and DOR physiological groups were lower as compared to the normal group. So concentration of melatonin in the follicular fluid of NOR group was significantly higher than in their serum. A significant correlation was discovered between melatonin levels in the serum and follicular fluid and parameters of ovarian reserve and embryonic development. So melatonin is very important, and I think sleeping on time and consuming melatonin can definitely help these patients. Growth hormone is believed to act on the body and augment follicular genesis via insulin-like growth factor or by direct action of growth hormone itself. IGF-1 receptors are present within the oocytes and the granulosa and the theca cells, and the growth hormone stimulates serum and follicular IGF-1 and hepatic production of IGF-1. And you can see this forest plot of the oocytes collected. Definitely, the odds ratio is 2.1, and it favors the growth hormone. For the outcome in the live birth rate, it is 1.71, the odds ratio, and it definitely these studies also favor growth hormone. So I would like to summarize my talk by saying that poor responders constitute a very heterogeneous cohort. Common denominators, of course, giving less number of eggs. We have a huge plethora of strategies and stimulation protocols. But with 30 years of experience, what we have done is, I think all of us have come to this, that adjuvant therapy with DHEA, coenzyme Q10, and melatonin and growth hormone definitely works. You use an antagonist or agonist protocol. Antagonist protocol is easier to give and much safer. And evidence does suggest that melatonin supplementation can ameliorate intrafollicular oxidative balance, improve quality and quantity of oocytes, and improve IVF outcomes in women with DOR and infertility. So thank you very much.
Thank you very much, Nandita, for the excellent presentation and sharing all your secret recipes to deal with diminished ovarian reserve. Can I ask one question? And that is, how long before IVF would you start CoQ?
Ideally, 3 to 4 months, because the oocyte cycle is 120 days.
I think that's a very good tip.
You don't have that much time. Your patient will go from one doctor to the other. So start as soon as your clinic, and by the second or third stimulation, you will be in 120 days.
Yeah. And in your one slide, you said you talked about FSH, luteal phase FSH start protocol. So can you let us know a little bit about that, please?
Time was limited, so I couldn't go into it. But yeah, what you do is you do the pickup. You do not pick up, you only pick up the big follicles. Remember, anything less than 10 should be just kept behind when you do one pickup. Then after 3 days, we just start the stimulation again, FSH. Or I prefer HMG. So HMG, I start immediately and then start monitoring. Previously we used to do the sonography, see if the follicle is there, do E2 levels, give GnRH antagonists. All that is not there now. You just can start on day 3 after the pickup or day 2 after the pickup.
So it is the second part of the routine or ovulation induction.
After pickup. So you just start it and then you use the antagonist to prevent surge. I don't know if this. We use antagonist, but people are using progesterone also to prevent the surge. And then, but the only thing, remember, you have to use the trigger of HCG. You cannot use a analog trigger in the first one.
Okay. And another thing was dose of growth hormone. How much growth hormone do you use?
Normally 8 international units for a woman who is 60 kilos and below, and 12 if she's above 60.
And starting from the day of stimulation?
2, yeah. But there are protocols, Asha, which give 1 month of growth hormone. So they use 6 or 4 international units for 1 month.
My God.
Yeah.
Very expensive, but yes, when you're not getting eggs, then it is worth it.
There are some patients who say that they'll do anything to get their own eggs. So I think this kind of a thing really helps those patients.
True, true. I can't see any other questions on the chat box. Are there any other questions? No. So I think thank you very much for the lovely talk and so many tips we got. And thank you, Alembic, for sponsoring this session. Thank you.
Thank you, Atul, Suri. Thank you. The whole Alembic team. I remember Akash. And Abhijit. Yes. And Subbu, of course, for his support.
Thank you.
Hi,
Yeah.
thank you,
Dr.
ma'am.
Abhijit, would
Thank
you
you,
like to
everyone.
give the vote of thanks?
Just to
Dr.
conclude,
Abhijit
good
or
evening,
Akash?
everyone. So this evening has been enriched by the insights of our esteemed speakers and moderators, whose contributions have illuminated a path forward in gynecology. It started with Dr. Amit Patki, with the Master of Ceremony, then Dr. Cheman Kanan ma'am and Charmila Ayayu ma'am, who have skillfully guided us through a series of enlightening discussions. Finally, Dr. Nanda Palshetkar ma'am and Dr. Asha Bakshi ma'am each have shared their invaluable perspectives, underscoring their knowledge on the topic of ovarian stimulation. So thank you so much, ma'am. We at Alembic Pharmaceuticals are deeply committed to innovation and excellence in healthcare, driven by our mission to empower healthcare professionals and improve the patient outcomes. And lastly, thank you to all my attendees and participants. Your presence and engagement has been instrumental in making this event a success. So thank you once again for joining us for the Ovarian D plus KBB webinar. And I hope to see you all again very soon, ma'am.
Thank you.
Thank you, everybody.